Your doctor just scheduled you for a routine screening, and you probably didn't question it. Most people don't. But there's something genuinely important in modern geriatric medicine that doesn't get talked about enough, which is that some routine tests, when used in a one-size-fits-all way in older adults, can lead to more harm than benefit. This isn't a fringe opinion. It reflects real, published research and is part of an active, mainstream conversation in geriatric medicine about a concept called overdiagnosis. I'm here with Human Health Zone, and today we're going to walk through 4 areas of medical testing where the evidence in older adults is more complicated, then more screening is always better, using real research, while being honest about where the evidence is strong and where it's more uncertain. Before going through them, there's one concept that reframes this whole conversation: the diagnostic cascade. A routine test finds something. That something looks like it could be a problem, so a follow-up test is ordered. That test raises a new question, leading to a specialist referral. The specialist recommends a procedure just to be sure. The procedure carries its own risks, and sometimes those risks materialize. This is a well-recognized pattern in the medical literature on overdiagnosis, not because doctors are careless, but because medical systems are generally built to investigate findings once they appear, and not every finding in an older body needs investigating. To illustrate this, imagine a healthy, active 73-year-old who goes in for a routine annual exam, feeling completely well, and one screening test comes back with a mildly abnormal result. That single finding can, in some real documented cases, set off a chain of additional tests and procedures, some of which carry their own complication risks, for a finding that may ultimately turn out to be clinically insignificant. This is a realistic, well-documented pattern, not a guaranteed outcome, and illustrates why the question of what happens after a test matters as much as the test itself. A second important concept: many medical screening guidelines were originally developed and validated using research on younger or middle-aged adults, then extended to older populations without always being specifically retested in that age group. The balance of risk and benefit that makes a test sensible at 50 can look different at 75 or 80, and that recalculation doesn't always happen explicitly during a routine appointment. Let's go through 4 areas where this matters, starting with routine whole-body CT scans marketed as a comprehensive preventive health tool. The core problem is that when you scan an entire body in an older adult, you'll almost always find something: small lung nodules, benign cysts on the liver or kidneys, minor age-related spine changes, simply because human bodies accumulate incidental, harmless changes over decades. These are called incidental findings, and once they appear in a report, standard practice generally calls for following up on them. Research on whole-body CT and MRI screening in healthy adults has consistently found high rates of additional testing triggered by these incidental findings, often without a demonstrated improvement in long-term health outcomes, which is part of why the American College of Radiology has stated there isn't sufficient evidence to recommend routine whole-body CT screening for people without symptoms or a relevant family history. There's also a real, if often modest, cumulative radiation consideration with repeated scanning, and older cells generally have somewhat reduced capacity to repair radiation-related DNA damage compared to younger cells. The practical question worth asking before any scan like this: do I have symptoms this particular scan is specifically meant to investigate? If not, it's worth a real conversation before proceeding. Quick disclaimer here in the middle of the video: this is general medical information based on published research, not personalized medical advice. Every person's health history is different, and some individuals have specific medical reasons that make a given screening appropriate for them regardless of age. Please have these conversations directly with your own doctor before changing anything about your scheduled care. Second, routine bone density, or DEXA, scanning in very elderly patients, generally meaning beyond age 80, deserves a more careful conversation than it usually gets. DEXA scanning is genuinely useful and well supported by evidence in women in their late 50s through their 70s, where finding low bone density creates a real opportunity to meaningfully reduce fracture risk over the following years. After 80, the situation becomes more nuanced. When a DEXA scan finds low bone density in a very elderly patient, the standard response is often a bisphosphonate medication. These medications are well established and effective at reducing fracture risk for most patients, but they do carry rare, well-documented risks, including atypical femur fractures and, less commonly, osteonecrosis of the jaw, particularly with long-duration use. It's worth being precise here. These risks are real but uncommon, commonly cited at around 1 case per roughly 2,000 patients with extended treatment, and they're more closely tied to how long someone has been on the medication than the age alone. The broader point geriatricians make is that for very elderly patients, fall prevention, strength and balance training, home safety modifications, and reviewing medications that cause dizziness all have strong evidence for directly reducing fracture risk, sometimes more directly than treating a bone density number in isolation. A reasonable question if a DEXA scan is suggested after 80. Will this result meaningfully change my treatment plan beyond what a fall prevention conversation would already recommend? Third, carotid artery ultrasound in people without any stroke-related symptoms. The carotid arteries carry blood to the brain and can develop fatty plaque that narrows them over time, which sounds like an obvious case for early detection and treatment. The evidence here is genuinely more complicated than that intuition suggests. The surgery used for significant carotid narrowing, called carotid endarterectomy, carries its own real risk of causing a stroke during or shortly after procedure, since working on plaque near the brain's blood supply is inherently delicate. In patients who've already had symptoms, a stroke, or TIA, this surgery has clear, well-established evidence of benefit. In asymptomatic patients, the picture is murkier and more age-dependent than often presented. Large trials, including ACSD1, have shown a real, if modest, reduction in stroke risk from surgery even up to around age 75, particularly in patients with high-grade narrowing. But the genuine controversy concentrates mainly in patients older than 75 to 80, where some research has found the surgical risk may approach or exceed the risk of optimized medical management alone, especially as modern blood pressure and cholesterol treatment have substantially lowered the baseline stroke risk compared to when many of the original trials were conducted decades ago. The American Heart Association does not recommend routine carotid ultrasound screening in people without symptoms as standard practice. If your doctor recommends a scan, especially if you're in your late 70s or older, a fair question is, if this finds significant narrowing, what does the evidence show about surgical risk for someone my specific age compared to optimizing my blood pressure and cholesterol medications instead? Fourth, and the one I think carries the most serious potential consequences, aggressive cardiac catheterization following a positive stress test in someone with no cardiac symptoms at all. Here's how this typically unfolds. A person over 65 with no chest pain, no shortness of breath, and no fainting gets a routine stress test as a preventive measure. It comes back abnormal, and a cardiologist recommends catheterization, an invasive procedure that threads a catheter into coronary arteries to take direct images. This procedure carries real risks in older patients: bleeding, arterial injury, kidney stress from the contrast eye, particularly in patients with reduced kidney function, and a small but real stroke risk during the procedure itself. Here's the part that genuinely surprises people. 2 landmark, well-replicated trials, Courage and Ischemia, both published in the New England Journal of Medicine, found that in patients with stable coronary artery disease and no significant symptoms, adding catheterization and subsequent stenting or bypass to good medical therapy did not reduce the rate of heart attack or death compared to optimal medication management alone. This is a well-established and widely discussed finding in cardiology, not a fringe claim. Stress tests also have a meaningfully higher false positive rate in older adults, particularly in women, meaning a positive result in someone with no symptoms can trigger a cascade of further testing and procedures that current evidence suggests may not change outcomes, while still carrying real procedural risk. Before agreeing to catheterization without symptoms, a fair and important question for your cardiologist is, given that I have no symptoms, what does the evidence show about outcomes for people like me managed with medication alone compared to those who proceed with the procedure? So here's the single question worth carrying into any of these conversations. If this test finds something, what will we actually do about it? And is that worth doing for someone at my age and in my current health? Asking that question before screening, not after a finding, is what creates space for the cascade conversation to happen on purpose rather than by default. To be completely clear, none of this means avoid your doctor or skip valuable preventive care. Blood pressure management, diabetes control, vaccinations, vision and hearing checks, and regular medication reviews all have strong, well-established evidence behind them, and remain genuinely important at every age. The goal here isn't to create fear about medical care. It's to help you walk into these specific conversations about full-body imaging, bone density treatment after 80, carotid screening without symptoms, and catheterization without symptoms. Prepare with the right question so that the decision is made deliberately with you rather than automatically around you. If this gave you a clearer, more honest picture of an important and often under-discussed topic, take a moment to like this video and subscribe to Human Health Zone. If you've experienced a testing cascade yourself, sharing that in the comments could genuinely help someone else walking into a similar appointment. We'll see you in the next one.